Good morning, everyone. My name is Christina Mangurian. I'm the Vice Chair for Diversity and Health Equity in the Department of Psychiatry and Behavioral Sciences. I'm absolutely thrilled to introduce and welcome Dr. Lisa Dixon, the Edna L. Edison Professor of Psychiatry at Columbia University, where she directs the Division of Behavioral Health Services and Policy Research. There, she oversees activities for the New York State Office of Mental Health in implementing evidence-based practices for people diagnosed with serious mental illness. Dr. Dixon is an internationally recognized health services researcher with over 25 years of continuous funding from the NIH and the VA. Dr. Dixon's work has focused on improving the quality of care for people with serious mental disorders. She's also the editor-in-chief of Psychiatric Services and has a really great podcast that goes along with that. I encourage those of you who haven't checked it out to check it out. And she's published more than 250 articles in peer-reviewed journals and won numerous awards, including the 2009 American Psychiatric Association's Health Services Senior Scholar Award and the Wayne Fenton Award for Excellent Clinical Care. The National Alliance of Mental Illness has also recognized her with the annual Scientific Research Award, and she works on 2 committees of projects sponsored by the National Academy of Sciences, Engineering, and Medicine. I personally had the absolute pleasure of working and meeting Lisa very early in my career when I was a fellow and then junior faculty member at Columbia. I've always looked up to her, given her absolutely brilliant mind, generous mentorship, pragmatism, and passion for improving the lives of people with mental illness. I've gathered so many pearls from Lisa over the many years that I've got to work with her, and I really look forward to all of you gathering some pearls of your own today. So please join me in welcoming Dr. Dixon. Hello. And then before we formally start, hopefully you saw a couple of claps there, Lisa. I know it's hard because you can't see everybody. Before we formally start, there will be a Q&A session at approximately 9:20. If you have questions for Dr. Dixon, please submit them via the public chat box. Or if you'd like to ask a question, click on the reaction button and there you can raise your hand. If your name is called, the host will unmute your microphone. It's going to be hard for you to unmute it yourself. And please be sure to change your name on Zoom if it isn't identifiable now, so I can call on you by name. Thank you. So passing over to you, Lisa.
Okay. Thank you so much. You can hear me? Everything cool? All right. Thanks much for Christina. It was a very generous introduction, and I can only say that one of our saddest days was when Christina left, much to your benefit and our loss. But you know what? In the big world of trying to make healthcare better, it's great to have all of you at the table. So I'm the last, I don't know, now maybe 10 years, I've really been focusing a lot on early psychosis care. And so I'm open to any questions about this, but the focus of my talk is going to be on sort of how we've built this learning healthcare system and what that means and what it doesn't mean. Let's see now. Okay, so I just want to acknowledge that as you'll see, this kind of talk that's a little bit sweeping, really builds on the work and contributions of so many others. And that's one of the wonderful things about the department where I have the privilege of working, that there's just great teamwork between the New York State Office of Mental Health, which is the public state entity, and our clients, teams, et cetera, et cetera. We also have a wonderful school of public health right next door. So in terms of disclosures, I do have some NIMH funded grants. I think probably the more important disclosure for me is that I have a brother with schizophrenia. He became ill right around the time, right around the usual time that people become ill, when they're just sort of starting their independent life. And he was actually in medical school when he became really acutely ill and got thrown out of medical school without even a message or information. Anyway, I could go on about this. He's really had a very difficult course. It really affects me, and it affects our whole family. And so sometimes my voice gets a little quivery when I start to think about this, but it really, in some ways, I think my focus on early psychosis care is probably a reflection of how painful and difficult that time was in all of our lives. So I'll be talking about what is a learning healthcare system, and then the On Track New York network, where are we now vis-a-vis that, and then what have we been doing to sort of strengthen our learning healthcare system network, and how has that how has it all worked out? And I am a very practical person, so I'll probably drop off a bunch of the theory and just get to the action more often than not. Okay, so what is a learning healthcare system? I didn't really know this until we had to write a grant in which we described it. But it's really like a quality improvement cycle. It's a healthcare systems, but at the system level, in which knowledge generation processes are embedded in daily practice to produce continual improvement in care. And I was looking at this, I was like, oh, I quote Wikipedia in my academic talk. Anyway, that amused me. So here's like a representation of the learning healthcare system and its phases. And I think it's all very logical. You have sort of, you're looking at the scenery, you're seeing what's happening. You have your model, you apply your model, and in this case, perhaps, a change that you might make. You collect data to show or not show that it works. And I would emphasize that both qualitative and quantitative data are really useful here. Use evidence to influence continual improvement. So adjust, change, shift, disseminate, and then the cycle just keeps going. So you're never really static. You're always growing, changing, and you may be, for different parts of your system, you may be having different stages or steps of the cycle for different aspects of your care. So you may be, working on your medication prescribing, or you may be working on your family outreach, or you may be working on, informed consent. All these things can be kind of all these moving parts and be at different phases of the learning healthcare system. This is just a slightly different representation of it. The one thing I do want to emphasize, and it is quite challenging, so but it's important, which is this notion of including key stakeholders to ensure that solutions meet their needs. And in my experience, that piece is easy to bypass because it's very labor intensive, but it's so important. And if you take away anything from this talk, I want you to take that away and just sort of keep it in mind and remember that you have to, that's just not a step to overlook. So EpiNet is the early psychosis intervention network, and you all in California have an EpiNet site for your early psychosis program. And I know many of you are familiar with this, but this is EpiNet is the NIMH funded network that has attempted to create a learning healthcare system across hubs. But in my view, I thought the idea was that each of the hubs is a learning healthcare system, but it's interesting that I think there's actually some confusion about this, even amongst the PIs, that, are we supposed to be overall a learning healthcare network, or are we supposed to, or is the learning healthcare system at the level of the hub, or even is it the level of the program? And maybe it should be all of the above. So, I'm going to come back to this, but I just want to start with what our aims were for our proposal as we thought about what we were doing well and what we weren't doing well in terms of, or what we could do better in terms of our learning healthcare structure. And I'm going to explain all this to you. So, but we really are, aim 1 and 2 are where the action is for us right now. Stakeholder involvement, data collection and informatics. And that's what I'm going to be spending some time on. Okay. So actually, so here we go, the On-Track Network. What is it? What is the On-Track Network and where are we now? So this is our lovely logo and positioning statement. And one of the very first things that I did or was asked to do when I moved from Maryland, where I had been for many years, back to New York, was figure out what the name of our program was going to be. And we actually hired a firm, a company that is really like a public relations messaging kind of company in healthcare to help us with this, because we understood from some of the preliminary work we had done how important a name is, right? So On-Track New York, my health, my choices, my future. You will notice that there is no word psychosis in our name. And that was really very deliberate and by design. And you can see our quote unquote positioning statement also does not have the word psychosis in it, because that freaks people out and it scares them. This is our model. It was a model that we devised as a part of our initial RAISE study. All of these models are multi-element, multidisciplinary. They all became so-called coordinated specialty care, but you can see the different treatment components. Key in work with young people, and actually all people, but is outreach and engagement. Peer support was something we didn't have at the beginning, but we added. And all of this is packaged in a shared decision-making frame. And what that means is, if someone does not want to do supported employment, they do not have to. If they don't want to take medication, they do not have to. The point being that, these are offered, they're discussed, we do, it's probably not what are the risks, the formal shared decision-making probably doesn't fit all of these, but the basic ideas of shared decision-making are sort of a part of what the individual gets or doesn't get or chooses to have or not have. In New York State, this is different in every state, and probably in California, in California at every county. The ages of eligibility for our program called On-Track New York, as I said, 16 to 30. We did not include people with non-affective psychotic disorders, only people with psychotic affective disorders. Sorry, let me say this again. We did not include people with affective disorders, with psychotic affective disorders. It's all non-affective. Duration of illness, individuals had to be within 2 years of the onset of psychosis. And you can see here the growth of our program. The initial commissioner who sort of was the visionary for this was Mike Hogan, and then we've had several commissioners since then, and our current commissioner, Ann Sullivan, is very committed to making this program available to every young person in the state who needs it, regardless of insurance status, whether they have insurance or don't have insurance or have Medicaid. And so this is required, because of the lack of essentially appropriate reimbursement, which we're working on, this has required a state allocation. And you can see here, that we were able to increase our number of teams at the time of the mental health block grants. And now we're in the middle of another expansion with the recovery funds. Here's a map that shows you where the programs are. It does not have the programs that are going to be added in the next several years. You can see, I think, clearly that we're in population centers in New York State, and it's always a challenge. New York, it's very important to think about the rural areas, but of course, as a population-based illness, that the smaller the population, the lower the numbers of people who are going to require this service, and mental health services are not that easy to come by in some of these more remote areas of New York. But this is something that we actually actively work on. But I'll be talking to you mostly about the programs that are these consolidated team-based models in the more populated areas. You can see that we have quite a few programs in New York City. Okay, so now I have to have a brief digression because in order to understand how we do this, you need to understand the Center for Practice Innovations. And the Center for Practice Innovations is, I direct that as a part of the division. And this is from sort of our mission statement. The mission is to promote the widespread availability of evidence-based practices to improve mental health services, ensure accountability, and promote recovery-oriented outcomes. Okay. What is it? What does that really mean? Is that just a lot of platitudes? Well, what it means concretely is that CPI is an intermediary organization. And when I was reading and I said, oh, that's what we are, it was very exciting because I knew we were something, but I didn't know that we actually had a name, and we do. And what is an intermediary organization? In the context of implementation science, it is an individual or group of individuals that acts as an intermediary organization between two or more entities to promote the implementation of model programs with fidelity and good effect. Defined as having a broader role to promote implementation, blah, 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 blah. So the bottom line is we are an organization that sits between the State Office of Mental Health and provider organizations and participants, service recipients, to promote, support the development of evidence-based practices. So we actually have, several, we focus on several practices, and here you see a timeline. So we started with dual disorders treatment. That was Mike Hogan and Susan Essick. The ACT Institute supports all ACT teams in the state, and we actually have a contract with some folks in the LA area to work with them so that, we have a lot of, modules and a whole variety of curricula to try to promote the deployment of ACT, and On Track New York is and the suicide prevention are probably our biggest initiatives. But you can see that that's what an intermediary organization does. An intermediary does multiple EBPs, a purveyor organization just does one. And and how do we think about what we do? This was something that when I got to Columbia, I'd always thought implementation science was like confusing and just a lot of blah, blah, blah. And I say that with all due respect. But it was when I came to Columbia and realized what we were trying to do, I saw the wisdom of sort of thinking in an implementation science framework. And I realized that, this is from the Consolidated Framework for Implementation Research, a very famous paper by Schroeder in 2009, which sort of put together all these different dimensions of implementation research and implementation science. And these were the sort of the 5 domains that we're most focused on. And for us, and for the work that we were doing at CPI, the inner setting and the outer setting were sort of they popped out as kind of, okay, that's how we're going to think about what we do. And then we layered on that, there's something called the Replicating Effective Programs Framework, which is developed by Amy Kilborn and others, which also just seemed to me to have is very logical. It had face validity. So you have these different phases. You have preconditions, pre-implementation, implementation, and maintenance and evolution. So if you're going to be implementing an effective program or replicating it, which is what we were doing, what are the steps you have to take? How do you think about what you do first, what you do second? Because it's actually not obvious. So I'm not going to go into detail on this, but this is just to say that this is kind of our Bible. Well, Bible is probably not the right. This is our guidebook. Okay. So that we have outer setting and then the different phases, inner setting and the different phases. And what we've actually done for each of our initiatives, we've created a detailed sort of graphic that shows you what we're doing in each of these boxes. Okay, so it keeps us accountable, and people get this. If I have to go to the commissioner, this is probably too many words, but at least she gets it. And you got to be able to explain what you do. So what are our key outer setting approaches? We work with the Office of Mental Health to develop clear expectations, develop incentives, and to embed expectations and expectation around fidelity into program structure. And these are our inner setting training and support. So we have a web-based learning management system, and you'll recognize most of these training strategies. It's actually not just a training strategy, it's an implementation strategy. But I just so you could get a sense. So that's what, so we go back to On Track New York. So think about, what did we need? I asked myself the question, this was way back in 2013, 2014. What did we need in terms of our work as an intermediary organization in order to make On Track New York, to scale it? Okay. And so these were the four things. And this is just kind of talking to people and reflecting back. So we needed access to state OMH leadership and ongoing dialogue. And so where do we sit? We sit in the office of the medical director with connection both to adult and children's services, because we span both adult and kids. We needed to have to deploy a model that was very consistent with OMH's vision. And we needed to make sure that we were always thinking about financing. We needed to have a connection to the regional leadership. So New York has 5 field offices, and the field offices are the first to sort of deal with issues and problems. We needed to have staff members who provide technical assistance, oversight, monitoring, and that's our On Track Central, and that's what CPI is, okay? And then we needed to have support for data collection activities. And this was the great wisdom of those who really began On Track New York. And again, I give all the credit in the world to Susan Essick and Marlene Radigan and Mike Hogan, because from the very beginning, we collected data. And in part, that was, I think, because we started as a research study with RAISE, but New York appreciated the need to maintain that investment in data collection. This is just a scheme of sort of how we view the creation of a single program. And again, I don't want to go through all of this, but just to say that, we now have a way of doing it that sort of maps onto that, the inner setting, outer setting, replicating effective programs framework. Okay, so now I'm going to talk a little bit about sort of where is On Track New York right now. And you can see we've enrolled about 2,500 individuals. You can see the breakdown by different characteristics. It's interesting that we have more males always, and these have been very, very consistent from the beginning of the program. We've had a little bit of a drop in the privately insured folks, but it's been pretty stable.
Lisa, can I ask a question? Why
Sure.
do you think there are so many? Why do you think there are more males?
I think, we know that schizophrenia, it starts at a somewhat younger age in males. And so, just by virtue of the fact that, we probably capture more of the men who have onset during our window of recruitment. And I also think that, men and males, have probably a little bit more of a disruptive early course, which gets them to treatment. So, it's a really good question, and I'd love to know the answer, but I've seen in other first episode programs that there is a preponderance of males, but maybe not quite as much as we have. So, okay, so we collect data on the status of individuals while in the program, but we also collect data on referrals and how people get into the program. And I just want you to see that we've had over 9,000 referrals, okay? And here you can see where they come from. So 46% come from the psych inpatient unit, 24% from outpatient mental health provider. And I'm sorry, these are so small, but I'm happy to share these slides with you if you want. 18% from self or family. And I think, we would love to see more referrals before people get to the inpatient unit, but this is what it is. This is now the outcome of the referrals. Okay, so you see that 26% of those individuals who were referred actually made it into the program. The largest cohort or group of people who did not make it into the program were 31%. The screening was completed, the individual's not eligible. So that actually, it turns out to be heartbreaking, some of the time, but at any rate, so you can see here, and this again has also been pretty stable. This slide shows you the engagement or ongoing retention in care. The program doesn't have a specific concrete length, but we say that the average, it's a time-limited program, and we say that the average length of enrollment should be around 2 years. And so you see here that we have 72% are still enrolled at 12 months and about 50% at 24 months. The way I think about this is that, this is probably not the time between enrollment and 1 year. That dropout during this period is probably not great, because probably, I just can't imagine someone getting enrolled and meeting the criteria for enrollment and not benefiting from this program for at least a year. But it's hard to know, and it's also hard to follow up people who've disengaged. I can make an argument that there should be some natural fall off between 1 year and 2 years that is reasonable and done in a thoughtful way. But again, these are things we don't know. We do have some data and we're looking at it, but we don't have any answers right now. What this slide shows you is that we provide our teams who supply us with the data. We send back to them their own report. So this is an example of a report that's sent back to a program where you can see two lines. One line is that team's engagement rate, and then the other line is the overall program engagement rate. So we allow our teams to look at themselves relative to the overall program mean. Here is another a way of representing hospitalization. So you see here the percentage of individuals with one hospitalization prior to in the 3 months prior to enrollment, and then the darker blue is with 2 or more. And you see here that obviously, the rates of hospitalization have declined tremendously. And, this is not a randomized trial. We don't have a control condition here. So you can't, we don't go around claiming that we've, independent of other factors, reduced hospitalization, although we do suggest it. I mean, it's what would the hospitalization rate be without this program? That's the question. Okay, and so we actually are, I'll share with you some things that we're doing to try to get, some kind of control. This is a percentage of individuals in work or school. And you see here, we peak at around 70%, and we're very proud of this. So the rate essentially more than doubles over time. And some of these people probably then leave the program. And so here again, you see a site level report. So the programs and in poorer areas and underprivileged areas, there isn't as high a rate of school unemployment. It's just not, it's not as much, it's definitely affected by the communities in which people live. Okay. So now I want to sort of just focus a bit on what we're doing in EpiNet and how we think about the learning healthcare system notion. So here is kind of a schematic around stakeholder feedback. So for the most part now, or at when we started, we've developed a way to transmit feedback and information from the teams and the clinics and the agencies to OnTrack Central by evaluation of by the evaluations of our technical assistants, and then we do like a needs solicitation. Like every 6 months or a year. And we get feedback from clients and families from a youth and family council. It's kind of not really all that robust, or wasn't robust. And we got feedback, OnTrack Central again, which is the intermediary organization. We certainly would get feedback from the commissioner. But again, that was not systematic or particularly, it wasn't contextualized properly or optimally. But yes, that did help us to do some QI activities. And then we would try to then, continue the flow and the cycle. When EpiNet, in our EpiNet proposal, we conceptualized the feedback by different sort of levels or tiers of participation. And so we have the tier 1 is this very intensive oversight and participation, which was our stakeholder work group, our executive committee, and then we really upgraded our youth and family councils, and sort of the creation of these technical assistant events for clinicians. And then the tier 3 was just sort of really much broader, trying to do surveys of participants and clinicians and our administrative. And you can see here the different types of activities. So, that was what we had sort of proposed. And, some of it we've been able to do, some of it we haven't. In our first year, so we're now like at the end of year 2, we did do prioritization surveys and in-depth interviews. So we had a team that tapped into sort of specific cohorts of representative stakeholders. We asked people, we did a whole bunch of sort of qualitative interviews on what they even knew about On Track, what their experience of giving feedback to the teams was. We created some, on the basis of some of that feedback, we created an infographic. And I'll show you some of these, but these were some of the activities in year 1. And you can see here that this was one of the documents that the AIM-1 team came up with, and we call ourselves Amplify. So the idea here is, amplify your voice, amplifying the voices of the On Track New York community, make your voice count. And so, so much of this is messaging and attitude, and providing a pathway in. And so we tried to do that. Here, I'm not going to play this for you, but it's on our website. There's an infographic that explains what the program is. People had no idea. I mean, if you think about it, well, why would they have an idea? But we worked with professionals to create these several animations. We got a supplement, a COVID-19 supplement, to try to understand what the experience of the pandemic was. I'm not going to show you all the results of that. These were this had 2 parts. One is a qualitative part, and then the other is quantitative. So in the middle of doing the quantitative right now to see if we can document any changes in outcomes and participation during this time and before, compared to before and after, and who knows what after is, but you can just see his interesting On Track New York telehealth positives, less anxiety, pressure, less time burden, easier, convenient, and everybody wants a hybrid, moving forward. And you can see what some of the suggestions were. And then we also have focused a lot on the individuals and clinicians, participants and clinicians' experience of racism. These are some of the suggestions. Increase the BIPOC representation on Track New York teams, provide anti-racism information and resources. So this is something that this is more like an example of the kinds of things, the kind of feedback we're getting and the kinds of things we're trying to do. And it's just very eye-opening to talk to people and ask them, what has it been like for you? Race-based discrimination, and an example quote, oh, here's something like someone will tell me, oh, my mom doesn't like you because you're Black. Again, language-based discrimination. And so these are the things that people bring to care with them. So again, just so you can see, this is a research summary. maybe it doesn't look so easy to dissect, but we tried to, we do all this research, right? And like, who even understands it or benefits from it or digests it? And so what we've tried to do, not just, for participants, but really for our entire community, is create these infographic, visually appealing summaries that explains the research. And, it's better than at least trying to read the paper. And, we do pilot test these, but, this is the kind of material that we're trying to make this so that it connects with the people who are our partners. Okay, enhancing the data collection and informatics system. And here you see our data flow. Again, it goes from the teams. So for the most part, at least at the beginning, we had just getting data from the teams, which then went to OMH. So we would get quarterly forms on each client, and then program components from the agencies. And now we've added self-report forms. This has been a part of our changes with EpiNet. And the data then gets aggregated, and we give both fidelity and monthly reports to the teams and clinics and the agencies. And you'll see that we're working on having that data go back to participants. And we've been able to take the data, de-identify it, and then use it for sort of papers, and we work with data science at Columbia. So here's sort of a diagram or a schematic of the data collection system. Let's see. And I just list some of the papers, just so you see, how privileged we've been in collecting data from the beginning of this program, and then having a system that organizes it and de-identifies it. These are some papers that are in process, and these are all the papers we published since whatever it is, 2014. Actually, the first one was published in 2017, and the most recent one actually in 2022. It's not completely updated, but trajectories of occupational and social functioning, persistent cannabis use, determinants of pathway to care. So we really, and it's not all pretty. It's not all pretty, I have to say, but we've been very committed to sharing the good, the bad, and the ugly. Not all of this is great news, but we do feel that we have a responsibility to use the data that we've been privileged to collect. I have this here. What this slide demonstrates is how we changed our data collection system, or enhanced it with EpiNet, which was, we realized that we had left out a number of things from when we started. So, we're trying to upgrade it. And one of the main things that we really are lacking still, and we're working on it, is discharge and what happens afterwards. So how are we enhancing it? Expanding our client self-reported data. And it's been harder for us to get, we have a lot of missing data with the client self-reported data. We've also linked to other data systems. So for example, while 50% of our folks are on Medicaid, we can at least link the Medicaid claims to our data set, and we can get actually a reasonable control condition, and we can follow people. And we're in the middle of a data validation process, because we have all this data, but I can't tell you how valid it is. I have no idea. It's just we get it from the clinicians, but can I say that it's 100% valid? No. Fortunately, none of our reviewers have really made that point. What we're working on now, again, is really trying to get to client level reports that are as close to real time as possible, that are useful to the clinician and the client. And, we have working with an expert in data visualization to sort of make that, make that more effective. Let me see here. And so here's it's just interesting. These are some of the data sets that we have in New York State. And this shows you what the overlap of these different data sets are with the on-track data set. So this is criminal justice. And you can see here we have a 5% Medicaid ID match for on-track for FEP 2013-19. So this is like another data set that was derived from Medicaid. And you can see, so this is 100% that match the on-track New York sample. And so, this allows for some kind of adjustment, but this will allow us to, this allows us to try to, speculate and also extend, the consideration of the overall relevance of our findings to the general population. And we have somebody in the Office of Mental Health, performance management and evaluation structure who's in charge of this. Like, we don't see any of the data, anything that's identifiable, and for purposes of research, we don't see it. We have a small part of our team that can see identifiable data that's in the system, but that's only for quality improvement. And we have a really, really firm firewall. That's one of the things that keeps me up at night. So we're working again on this client level visualization system, and we're using this program called Tableau. Again, this is more just conceptually. I'm not going to drag you through it, but you can see here that here are some of their working templates to contact information, participant characteristics, et cetera, et cetera. So, and this is a dashboard that, weight and BMI, this Myrick GAF score. So, an individual can see for an individual how they're different. We had been collecting the Myrick GAF, which gives you social, occupational, and symptom scales. And you can see how that flows over time. And here's a way we represent fidelity. You can see here, so here the red line represents the threshold for quote unquote fidelity. And you can see this is a particular team. They exceed the threshold. And this is for engagement, and this is the statewide standard. And this is for safety planning, doing safety planning when someone has an indication for safety planning. And you see here that they were doing very well, but then this particular team then fell off. And I think this is probably a pandemic related phenomenon. The final thing I'm going to share with you is our data science unit are trying to, we have a big sample of individuals, and so they're trying to use more of these fancy prospective analytics to see if they can create predictive models that would then in turn allow us to identify people who might need something different from the beginning, who might be more at risk for a poorer outcome. I mean, there are some ethical issues that are involved with this, and I struggle with them a bit, but the point being that we have a big enough sample and enough data that we can try to see if we can identify people at risk for not having the kind of outcomes they would want and they would need, and then try to help them in perhaps with enriched services.
You see, you have about 5 minutes left.
Yeah. Okay. Well, I'm literally just about done. So, and here again, this is, I'm going to read this because I'm not I'm not a statistician, but what Melanie is telling me is that we're at a point now where we can develop this so-called shiny app that visualizes predicted probability of education work over the next 4 visits, along with uncertainty about that prediction. So I don't want anyone to think we're going and using this in clinical care now. It's not appropriate and it's not ready. But the idea here is to be able to use the kind of really deep, rich data set that we have over time to identify what people's service needs are. And I guess the last point that I was going to be making is just that, well, if we think about the learning healthcare system, so, you learn about what is going right and what is going wrong, and then you take either corrective action or supportive action. And so sort of as I've already alluded to, our family and youth council indicated that people didn't understand what a learning health system was and the role of On-Track Central, or even that there were other teams. The things that were so obvious to us were completely invisible to participants. And so we developed this infographic, and we worked with our sort of councils to create these tools. And then the family council actually created a welcome guide. And now the youth council is creating a welcome guide that really cuts across all the teams. So there's been this nice interaction between the participant and the family. And this slide shows you some of what we've learned at the level of the providers. We had initially all these different fidelity. We had data reports, but our providers told us they couldn't really follow them. We thought they were perfectly logical, but the providers said they didn't know what was being reported here. And so they just said, could show us what we're doing relative to fidelity. And that's what we did. And that has really made a difference. And this is even sort of getting into the weeds, but we had these learning collaboratives for supported employment and education specialists that were based on program maturity. So the more sort of established the program was, we put those teams together. Turns out that wasn't really useful to the providers. They wanted it to be regional. And that, because then they could network locally. So this is, again, just trying to keep your eyes and ears open and try to do what's helpful. So, from my standpoint, I hope I've shown you that the learning healthcare system framework is useful and can promote evidence-based, measurement-based, and stakeholder-driven processes to improve care. It definitely requires some investment into infrastructure and attention both to stakeholder involvement at multiple levels and data measurement. And, there are numerous models and sort of model, riffs on models that can help create a roadmap. So that, and now I'm very happy to field any questions you might have or.
Excellent. We already have a couple in the chat, so this is perfect. And this work is amazing, especially the school and work outcomes are incredible. And I love the predictive modeling, just to be thinking about who needs help earlier so we can get at that. It's just so cool. So I'm gonna first call on Dr. Rachel Loewy. I think most of you know Dr. Loewy, but you may not know that she's also the co-investigator of the California-wide EpiNet, EpiCal, and also directs the California Early Psychosis Training and Technical Assistance Center. So I know she's a close collaborator of yours, Lisa.
Yeah.
Hi, Lisa. And just for those who don't know, the network that Lisa has set up in New York is the best by far in the country of the regional networks. And she's been really leading this. We look to the work that she's been able to do in New York. And Lisa and I talk a good bit about the differences in these two large states, where there is in New York a top-down process and California is very bottom-up. And so I guess one question I have, Lisa, you've talked about this before, and you started at the beginning of the talk, how important the intermediary organization has been in supporting that kind of work. and you talked about how important it was that you weren't I'm sorry if you can hear screaming children in the background, how important it was that you had an organization with other EBP rollouts, that it wasn't just alone. And I think that's one of the things we've struggled with, is we're working with different state funders and organizations around our statewide network, but kind of by ourselves. And I just wonder, we've talked about this a bit, about, what alternatives, if there are any, you can imagine, or ways of doing it if you didn't have that support. I don't know if you can imagine that.
Yeah, well, I mean, I think I have so many friends in California, and actually family too, but that, and talked a lot about this. The funding structure in California is different. The leadership structure, but I think that there definitely are strategies that can, maybe by breaking down the different components. So you have the technical assistance around delivering the model. You have the whole issue of data, and maybe you're not going to get the same kind of data in each of the communities or counties, but so maybe you need to sort of localize that and figure out the roadmap back to sort of more of a statewide technical assistance center. But it would seem to me it makes it all the more important to have this notion of an intermediary organization, because nobody in state government's going to be doing this, and at the level of the programs, they can't do it either. So there needs to be some entity that has some. It doesn't have to have a lot of authority, but it needs to have some. It needs to be empowered in some ways, and it doesn't have to be all through sticks. It can also be through carrots. And California is a big enough state. Maybe you don't get everybody, you get half, and then you show how helpful it is, and then others want to join in. And I think you can build on California's diversity, because you have, instead of having, we're top down to the extent that, the state has created, sort of one model, although it's of course deployed in different ways in different places, but you can take advantage of your diversity by trying to identify some central core, both outcomes and components, and learn. I mean, because I think that California does have this tremendous advantage of having all the expertise, really way earlier than we did in New York, and I think a sense of community, which I don't think I've seen in some of the other states. So.
Yes, so interesting, the differences. Yeah. So we've got a couple of questions. We've got Nick Canas. Nick, did you want to unmute yourself?
No, I am. Okay, hi. Yeah, Dr. Dixon, thank you very much. I really enjoyed your presentation. I have been interested in doing group therapy for psychotic patients for decades. I just wrote a book on that topic. And I feel sometimes that I'm like pushing a rock up a hill, because it seems in the last 10 years or so, we've gotten much more into just medicating psychotic people, and that's it. And I was very pleased to see the breadth of your programs. And I'm wondering if you could comment on the role of individual and group therapy for psychotic patients, particularly, and also what is the models that you have found in your program that you have been using for treating people in this kind of, say, group therapy? Okay,
so let me just say one thing, that like, if all we offered were meds, okay, we would have nobody in our program, or almost nobody, because that's just that's really not. I mean, I'm being a little bit dramatic here, but what do people really want? That's what we have to try to engage them on. And for the most part, they want their lives, right? Mm-hmm. They want, hobby or their girlfriend or their boyfriend or their basketball game or whatever it is, right? And so I think that this notion that, it's, get your prescription, this notion of coordinated specialty care, which is sort of this movement, excuse me, is really all about the multi-element, multidisciplinary approach. And so if you go like on the NIMH website, you see the definition of coordinated specialty care, which is what I showed you. And you'll see that you would be doing a terrible job. You wouldn't be doing coordinated specialty care if all you did was give meds. Okay. Now that being said, each of the different models and programs, does approach the issue of therapy in a different way. And you'll notice that in the definitions, it's not super prescriptive. Okay. And in our program, okay, so I'm just going to talk about the family side for 1 minute, because I'm like, obviously I have very strong feelings about this. And it drives me absolutely batty when every family member is put into a family psychoed group. Okay. That's in the same, we have to be family centered and person centered. So we have to find out preferences and we have to see what works for a particular family. So for some families, they want consultation. For some families, they want a more structured family-based group. For some, so, and it's very culturally driven. So I think that, so it would be the same to some extent for individual and group therapy, that I think we have to have some choices, regardless of what we include in the choices. All right. And, there are, CBT is obviously, you guys are, I have been the creators and disseminators of really valuable CBT in early onset, in first episode work. The Navigate program led by John Kane, the RAISE ETP study, they developed IRT, individual resiliency therapy. We have a sort of a little bit of a mishmash of probably both of those, CBT and IRT. And in terms of, but we try not to be, at least in our oversight, we try to be flexible, because we think it's worse. We think it's worse for programs to become rigid than it is for them to be a little bit, not systematic. Now, that's a judgment that we make. In terms of groups, it's very interesting, because we haven't required groups. And so with the programs that want to do groups, we've been very supportive, and it would be sort of the same kind of approach with, cognitive behavioral strategies, social support. But it depends on what's driving the desire for the group. But I think there's a lot of room for dialogue, and even for you to share, for your work to be sort of offered. I think that in terms of like very intensive psychodynamic or analytically oriented therapy, there's probably not that much of analytically driven, but I think sort of psychodynamic principles are always, part of the,
Yeah, it's so interesting. And it's interesting that I want to call on somebody who wanted to speak, but it seemed, speaking to this with groups, that some of the people in the COVID kind of supplement were saying they really wanted groups, but that goal seemed to be much more social, as opposed to treatment for logical reasons. So the next person who you may know as well is Demian Rose. Demian?
Hi, thanks for that comment you just made. I really appreciate it. My read of the data is that the good outcomes we see in these programs is not because we have some magical ability to pick the right medication, right? And I think that's a problem. Maybe the system focuses on a little bit too much, this disease model approach. My question is related to that sort of issue of maybe, sometimes physicians thinking of sort of dopamine blocking as an end as opposed to a means to an end. I'm wondering, now that you've been going for a while, if evidence-based treatment, it's not only maximizing the benefits, I might think about it as minimizing the harms.
Yeah.
Is there any data on, say, metabolic parameters or polypharmacy or overdosing or things that you might say would indicate a reduce in harm in a program like this versus just a benefit?
I have to say that is such a really important point, and I like that a lot, and I think I'm going to use it. And yeah, we follow. I mean, I should just say I don't have the data here, but we really closely follow medication prescribing. And I always say, if every single patient's on medicine, if it's 100%, something's wrong. Because they're not they're not listening to the patient.
Right, because 25% of them don't respond to medication. Right?
Yeah, so you have
That's
people
what the data would suggest.
Right, you have people who don't respond, and then you just have people who don't like it. So
That
who may
harms them.
respond. Yeah, so it's harder to get the prescribers to the table. They're all so busy. But
everybody's busy. That's not a great excuse.
Yeah. So, but no, I think you're right on. And as far as I'm concerned, it's all about engagement. If we just focus on our unidimensional pathological framework, we won't have any. Our rates of engagement will be even lower than they are.
Well, I know we're at time now, so maybe folks can take themselves onto video and just give Dr. Dixon a big hand of applause. Some applause here. Thank you so much. This was videotaped, and so it will be available on our website if folks want to watch it or spread it. But Lisa, it was just incredible having you here. Thank you so much for all the work that you
My
do
pleasure.
with others.